deficiency. Yes. It is megaloblastic or pernicious anemia. Yes, but also we have what kinds of anemia? Hemolytic anemia, yes. Hemorrhagic anemia, yes, and another one. You need to know about iron deficiency anemia. How iron may be absorbed in our organism.
So iron will be absorbed when
it is 2 plus or 3 plus. Ferrum 3 plus or ferrum 2 plus.
From the 2 plus.
2 plus. 2 plus. To be absorbed, iron may need to be 2 plus. Yes? 3 plus we have in the blood. In food we have what?
3 plus.
3 plus.
3 plus.
Who make 3 plus into 2 plus?
The ferrum.
In stomach. Acid. Hydrochloric acid. We need hydrochloric acid to make from 3 plus iron or ferrum 2 plus. And only 2 plus will be absorbed. Yes? And then into the enterocyte, it again transformed into the ferrum 3 plus. Yes? And ferrum 3 plus can be bound with transporter. What transporter? Apoferritin make transport from stomach or intestine to the enterocyte. Apoprotein, yes? Transferrin take ferrum 3 plus
and store it.
Not store it will go into the blood, yes, and to the tissues. And then it can be stored in what form? Ferritin or hemosiderin, yes? Ferritin it is good, we can take from ferritin iron, but hemosiderin it is not very good because it cannot give to us iron. And if you will overdose iron,
it can cause like nausea, vomiting, or
gastrointestinal problems, or may lead to hemosiderosis. Yes, it is a disease. So the drugs which we can use to treat iron deficiency anemia may be divided into 2 main groups. What 2 main groups? Sulfas. The drugs which we can use orally and parenterally. If we speak about oral drugs, they need to be ferrum 2 plus or ferrum 3 plus. How do you think? What drug? What ferrum will be absorbed?
2 plus.
So it needs to be ferrum 2 plus. Or if we use ferrum 3 plus, we need to add something to convert. Yes? And usually it is ascorbinic acid. Understand this information? Yes?
Vitamin.
Vitamin C, yes, ascorbinic acid. If patient has some problems with stomach and don't atrophy maybe stomach, it will not release hydrochloric acid and ferrum 3 plus cannot be absorbed. Clear? It will lead to anemia. If we speak about parenteral usage, intravenously or intramuscular, what drugs we can use? Ferrum 3 plus or ferrum 2 plus?
3 plus.
Only 3 plus. And we have some drugs. Vercoben, venferon, yes, which we can use intravenously. And ferrum lec we can use intravenously and intramuscular.
Why should it be 3 plus intramuscular?
Intramuscular ferrum lec. We have the drug ferrum 3 plus and the name of drug ferrum lec. Ferrum lec. Or you can name another which you have in your book. Ferrum lec it is a trade name. It is ferrum 3 plus. If we speak about ferrum 2 plus, it may be sulfate, fumarat, yes, and glutamate, and any trade name of these drugs. Yes. If patient have problems with kidney, it may lead to decrease erythrocytes, not hemoglobin, erythrocytes, because kidney release what? Erythropoietin. It is growing factor to erythrocytes or red cells. Yes, red blood cells. So if patient have problems or kidney deficiency, we need to use erythropoietin to increase the amount of erythrocytes. without RNA, the cell cannot be replicated. Yes, we need DNA and RNA to be replicated. If you have cell but don't have DNA and RNA, it cannot be divided, but it will grow. Yes, and it may lead to megaloblastic anemia. What about folic acid?
Folic
The
acid.
same, yes, we need the same. But what is the difference between vitamin B12 and folic acid?
B12 has neurological disorders.
Yes, because we need to synthesize myelin, also vitamin B12, yes, for example, copolamine. And if patient has some neurological problems, it means that he has vitamin B12 deficiency. Good. What we need to absorb vitamin B12?
Intrinsic factor.
Intrinsic factor, yes. And if patient has some problems with intestine, will be absorbed vitamin B12? No. Do you know that the main not depot, source, yes?
From meat.
Animal
products.
Yes, and what else? Our microflora in the intestine. So if patient has this bacteriosis, yes, it may lead to vitamin B12 deficiency. Yeah. How we can use vitamin B12? For example, copolamine. Parenterally, because it is not very useful to use enterally or peros, because if patient don't have problems with intestine, it will be absorbed from the milk. Yes? So usually we use parenteral. Folic acid we can use and usually we use. Do you have questions about anemia?
Folic acid
Orally, because we don't need any factor to absorb folic acid. Yes? Only give tablets and what about leukopenia? What we can give to the patient to increase leukopenia? Stimulating factors. They will stimulate our bone and bone marrow and increase their release of this or growth of these cells. What drugs do you know? Sodium nucleonate, it is not growing factor, it is a part of purines or pyrimidines. Yes. Ingrastim, yes, ingrastim.
Malgastrin.
Molgastrim, yes, it is growing factors. Pentazim, it is not growing factor, it is synthetic drug. Sodium nucleonate, it is synthetic drug, and methyluracil and pentoxil, it is synthetic. They are used to make synthesis of some parts of the cells, yes? But if we speak about growing factors, it is lengrastim, molgrastim, filgrastim, or you can say colony stimulating growth factors, if you don't remember the name of the drugs. Yeah. On control you have stimulants of leukopoiesis. So you need to remember. Any questions? No. Now we will start with hemostasis. How many parts of hemostasis do you know? Three. First of all, if you have wound in the vessel, what vessel needs to do? Vasoconstriction, yes. Then make aggregation of arteries, then coagulation, and then when vessel will be restored, phenobrenose. So we have aggregation, coagulation, and phenobrenose. If we speak about aggregation, who participate in aggregation? What cells?
Platelets.
Yes.
Van der Waal factors.
To activate platelet, we need some products in the vessel, yes? And it will activate platelet. A platelet begin to release what?
Thromboxane.
Thromboxane. Who make thromboxane? COX-1 yes? They bind with what? G protein.
GP1.
Q. Q means that it stimulates what? Phosphorus, like us. C. You remember this information?
Yes.
It made from inositol D phosphate, inositol 3 phosphate, and it increases calcium. And calcium will activate what glycoprotein? GP3A. And it will bind with fibrin again and another block. And you have aggregation. That's very good. But if you don't have problems without vessels will release something to prevent degradation. What? Which bind with what? With receptor, which binds with what? GS. Activate the and decrease calcium. So we will decrease calcium and prevent the aggregation. Okay, but if platelet is activated, it releases ADP, also ADP, which will bind with the receptor to AGP, GI, inhibit adenylysis flux, inhibit, and it will increase calcium. Adenylysis flux decrease, yes, but if you will inhibit, it will increase and lead to aggregation. Then cyclocane B may be destroyed by destroyed. Yes, this information you know. It is aggregation. Yes, to prevent aggregation, we need to do something to block this way, to block this way, or to activate this way. Yes, or to increase cyclocane B. So we need to the classification of antioxidants.
Okay, for the okay, we have action on hemostasis and action on hematosis. For the action on
anti-aggregants which prevent aggregation. So the drugs which will affect on the platelet and on this, what
okay,
we do?
We have 3 antiplatelets, antithrombin,
Anticoagulants and inhibitors.
and antifibroside.
So first of all, we speak about aggregation. How to prevent aggregation? What we can do, we say that we need to block the effect of
Okay, first
thromboxane.
we have COX-1, so we will use aspirin to inhibit the first stage, and it will affect on the arachidonic acid that will lead to decrease the formation of the platelets.
Aspirin, in what doses we need to use? Low doses.
Low doses.
Yes. What side effect may be? Bleeding and ulceration. Yes, you remember this information. Okay. This second drug, what is it?
ADP receptor blocker.
Blocker. What's the names of the drugs?
There's
Ticagrelor,
and it's slow action.
They have clop in their what? Yes. Ticlopidine and clopidogrel. Okay. What else we can do?
Third one is blocker, not blocker, it's a glycoprotein.
Drugs which will block glycoprotein. Yes. What?
Blockers like
Yes, we can block this. Okay. Read all together.
abscissima.
Eptifibatine and Let's you repeat please.
Abscissima and wait.
Eptifibatine and
Not
tirofiban.
this one.
Again, please.
Abscisimal
Mab,
mab and
tirofiban, ban,
tisoglilor.
eptifibatine.
Not this one.
What does it mean, MAB? Monoclonal antibody. If you have MAB at the end, it is antibody, monoclonal antibody. Clear? What else? Can we include increase the effect of prostaglandin. Yes. What drug we can use?
Epoprostenol and
Epoprostenol. It will increase the effect of prostaglandin. And what about inhibitors of phosphodiesterase? Can we use this? And pentoxifylline, if you, I think that you have pentoxifylline also in the methodical examination. Do you have questions about antiagregants? They all may lead to bleeding, yes? And if we speak about aspirin, it may lead to what? Ulceration. This is agregant. Good. It is antiagregants, but sometimes we need to to stop bleeding, yes? And we need to increase something, aggregation, something to increase aggregation, yes? What we can use? We say that to activate platelet, we need calcium. Can we use calcium solution? Calcium gluconate, calcium chloride. Yes. We say that to make, to stop bleeding, we need vasospasm. Yes? Can we use drugs which can lead to vasospasm? What drugs? Not. Terlipressin. Terlipressin, it is the analog of vasopressin. You have this information in your classification. Open the first page, please. Look, proaggregants, terlipressin, solutions of calcium chloride and calcium gluconate. See, you have this information? Yes. And ethoxylat. Ethoxylat will increase the amount of platelets and increase the aggregation. Clear? The second phase of hemostasis is coagulation. You know that we have how many ways? Two. First activate 11, then 9, and 10. And the second 7, and then 10. Who made 10 and the second? Yes? Do you agree?
Yes.
They will go, who makes synthesis of these factors? Liver. From what?
Vitamin
It needs vitamin K to make synthesis. In our liver, vitamin K it is water soluble or lipid soluble?
water.
Lipid soluble. And it can accumulate in the liver in two forms, hydroquinone and epoxy. And some enzymes will transform. Yes? If we speak about epoxy, it transforms to hydroquinone. Who transform? Reductase. And hydroquinone by carboxylase make epoxy. But carboxylase is its own activated when it makes from hydroquinone epoxy and goes to make synthesis of factors of coagulation. Yes? 7 and 9. Yes? So to make synthesis of these factors, we need vitamin K. If we speak about anticoagulants, they are divided into two main groups. If we speak about direct, they will affect only on activated factors. And the main what we need to inhibit it is N and thrombin. Direct factors, direct anticoagulants divided into two main groups. Yes, which we can use parenteral or oral. If we speak about parenteral drugs, they need something to help them to bind with them and the second factor. What they need? Antithrombin. Yes. Antithrombin, the main idea to bind with the second factor. Yes. Antithrombin, it is to thrombin. But we have 10 factor, and this 10 factor is very small. And antithrombin 3 can bind with, first of all, 10 factor. And then it can bind with the second. But to stabilize this structure, we use heparin. Heparin has sugar tail. If it has long tail, we say about high molecular heparins. Yes? And high molecular heparins can bind with 10 and second factor and stabilize the structure with second factor. But if we speak about low molecular heparins, they don't have large tail and can bind with 10 factor and sometimes with the second factor. And if we speak about fondaparinums, this drug also, it is not heparins, but it can bind with antithrombin 3 and bind with 10 factor. It doesn't have tail, only sugar part. Yeah. So drugs, anticoagulants for parenteral use, heparins, high molecular, low molecular, name the drugs. Low molecular and noxiparin, they have parin like heparin, yes, in the law. And fondaparinums also can be used, it is not heparin, can be used to bind with 10 factor. Yeah. Then we have some drugs to bind with 10 and second factor, which we can use orally. How will be two in your language? Two. In your language. Two. Do? How two? In your, do one.
In English,
Not in English, in your language.
abo,
Not your. So deca. So the first is D, yes? So dabigatran is to second factor. Yes? D at the beginning. Dabigatran. And 10 it is very large not name, not letter, but it is what is not letter?
Symbol.
Symbol, the symbol, large symbol. 2 is a small symbol, yes? 10 it is large. River, it is very large. So river of someone, it is for 10. I remember that. I don't know how you will remember. So to second factor, it will be dabigatran. To 10, river of someone. Is it clear? Clear. Then we say that to make synthesis of these factors, we need what? Vitamin K, hydroquinone. If we will inhibit this enzyme, we will not have hydroquinone and we will not have activated carboxylase. What drug will inhibit? Warfarin. It is not indirect, yes, indirect drug which will inhibit reductase. We will not have hydroquinone and we will not have activated carboxylase and we will not have factors. How do you think? If we speak about warfarin, it will affect very rapidly or we need the time? Why? Because in blood we have factors and we need the time to prevent synthesis of these factors. Yeah. Usually we give heparin and then during 5 days we increase the dose or the effect of warfarin, then stop using heparin and use warfarin. But if we use warfarin, we need to look at the rate. What rate? International. What the not about 2 and 4. Yes, 4. 2. Usually it is 2. You need only to make international laboratory. Okay. This is the drugs which will make anticoagulant effect. Yes, but sometimes we need to stop bleeding, and we need coagulation. Yes. What we can use? Can we use these factors? Vitamin K. Okay, we can use vitamin K. If we will overdose warfarin, I agree. Can we use these factors first of all? Do you know about hemophilia?
Yeah.
When patients don't have any factor, yes, maybe 8, 9 factor, we use these factors to prevent bleeding, yes? if it intravenously or intramuscular. Why? Because it is the main factor, yes? It may lead to thrombosis of all. How we use? We can take some tissue, solution with thrombin, put on the maybe liver when we have a surgical operation, stop bleeding, and then continue the operation. Yeah. Also, we have antidote to heparin. Who is antidote?
Five to seven.
So